Hello everyone, my name is Mohammad Faraz and I'm presenting my poster about the osteoporotic vertebral fracture prediction using CNNs. Osteoporosis is a metabolic disease which impacts bones, especially in spine and hip areas, making them fragile and likely to fracture. With early fracture prediction, there is a possibility of proper treatment in order to mitigate future fractures. One approach is to use CT scans of the patients which are taken due to other reasons in an opportunistic screening setting. Our approach is to first automatically localize vertebral bodies in this CT scan and then subsequently use a CNN to classify whether the subject will experience a vertebral fracture in the next 10 years. In this study, we investigate the impact of important CNN design choices, particularly how is the prognostic performance when using different CNN model architectures and whether we need the full 3D vertebral patch for good fracture prediction as compared to 2D average intensity projections. Now I will present the overview of our risk assessment pipeline, which consists of 3 stages: localization, classification, and fracture risk assessment. For the first stage, which essentially consists of vertebral localization and image processing, we use the part-based localizer, which is our in-house CNN-based point localization algorithm for localizing the vertebral center coordinates, and then we crop the fixed size patches containing a single vertebra centered on these coordinates. Although the 3D patches provide more spatial information, they are computationally expensive to compute. To investigate the need for 3D, we projected the 3D volumes into 2D images by averaging. For the second stage, we trained CNNs to predict whether the subject corresponding to a given vertebral body will experience incident fracture in the next 10 years. We investigated 2D and 3D versions of 4 architectures: FNet, ResNet 18, ResNet 50, and SE ResNext 50. For multiple vertebra, we compute a patient-level score by averaging individual vertebrae prediction. In the fracture risk assessment stage, we use a Cox proportional hazard model for survival analysis. The model used patient-level sigmoid scores, age, and BMI to compute individual fracture risk because these are known predictors and are easily available. We use the publicly available MrOS dataset, which consists of 3,800 male subjects, where roughly 2% have a fracture within the next 10 years after the baseline scan. The dataset was collected from 6 different clinical sites and show a significant variation in the image quality of the scan, which can be seen from different views of the example images below. Moving on to the results, we observed a moderate impact of the CNN architecture on the classification performance with respect to both AUROC AUPRC and C-index. We did not find any systematic difference between the performance of 2D and 3D architectures, although 2D models perform slightly better than the 3D, except in case of the FNet. The best classification performance was achieved by the FNet, which is then followed by the ResNet 18, where the FNet 18 has the lowest number of parameters among all models. Compared to the baseline C-index of 63% for age and BMI alone, inclusion of imaging data improved the C-index for all investigated model configurations. To conclude this presentation, we built and evaluated a fully automatic pipeline for osteoporotic vertebral fracture prediction and risk assessment, investigating design choices of the prognostic CNN classifier with regards to model architecture and the input image dimension. We found a moderate impact of the CNN architecture on evaluation metric and slightly better result for the 2D models. If you have any questions or are interested in more details about the study, I invite you to meet me at the poster 82 at the MIUA conference. Thank you.